Welcome everyone to this CIN webinar, Washington's statewide community care coordination and SWACH's HealthConnect Hub. Really excited for this conversation today. We'll get to hear a little bit about Washington's statewide community care coordination system and their community information exchange platform that they're using to improve health outcomes for their residents. Oops. All right, my name is Marie Hubbard, and I'm the program manager for the California Improvement Network, also known as CIN. CIN is a learning and action network that that is meant to identify and spread better ideas for care delivery, ultimately to advance the quadruple aim. We are fueled by the energy and innovations of our partners and members. So all of you on the call, thank you so much for your contributions to CIN and our work. CIN is a project of the California Healthcare Foundation and managed by Health Force Center at UCSF. We encourage you to go to our websites to learn more about our organizations. So a few just Zoom tips before we get started. This webinar will be recorded, so everybody is on mute except for our presenters. We will have some open discussion and Q&A at the end of this hour, at which point we'll invite you to open your line and have a discussion with our presenters. But we do ask that you stay on mute until then. If you're having any technical issues, please reach out to my colleague, Christina Travalos, and she can help assist you. So without further ado and ready to get into the content, I would like to introduce our presenters, Michelle Ahmed, who's the operations manager at HealthConnect Hub, Nicole Peppers, who's the networks manager at HealthConnect Hub, and Eric McNair Scott, who's the director of Community Clinical Linkages at Southwest Accountable Community of Health. So I will stop sharing my screen and pass it off to our presenters.
Okay. Thanks, Marie. I am going to share my screen and just make sure we're all good. Okay. Can folks see my screen?
Yep.
Okay, great. Well, hi, everyone. This webinar is focused on the HealthConnect Hub, a community-based care coordination infrastructure developed in partnership with community and clinical agencies in Southwest Washington. The presentation will cover 3 sections. First, we will share work around understanding different community information exchange models. CIE models that should be understood as distinct and potentially complementary are often conflated under a single CIE acronym. Second, we'll provide an overview of the HealthConnect Hub, a successful and evolving community-based care coordination infrastructure that has been developed in Southwest Washington. And finally, we will look at evaluation and sustainability frameworks for the HealthConnect community-based care coordination model. HealthConnect supports people in accessing the systems and resources needed for whole person care. So what do we mean when we say whole person care? Whole person care can be defined as the coordination of physical health, behavioral health, and social services in a patient-centered manner with the goals of improved health outcomes and more efficient and effective use of resources. The HealthConnect Hub centers and supports a trusted community-based workforce as the driver for improving whole person care outcomes. We know that change happens at the speed of trust. A trusted community-based workforce is central to this work. Washington's Medicaid Transformation Project provided significant funding and opportunities for innovation to advance whole person care. Community-based care coordination was one of 8 projects that ACHs could choose to pursue. Our organization, the Southwest Washington Accountable Community of Health, or SWACH, implemented the Pathways program as an evidence-based community care coordination model. This was the first community-based care coordination model supported by the HealthConnect Hub. Pathways launched 2.5 years ago. Today, the HealthConnect Hub supports 7 integrated community care coordination models. We're also partnered with our neighboring ACH Cascade Pacific Action Alliance, or CPAA, in an aligned community-based care coordination infrastructure that covers a 10-county area. Community agencies have reported seeing significant value in partnering as part of a community-based care coordination infrastructure. One of the leaders of a partner agency said, quote, "Before we were part of the hub, most of what we were doing was rental assistance. Now we can actually engage every client in a meaningful way. It's making a big difference for our ability to help people. Being in the hub has been like finding the holy grail for our housing services." The data on the last slide was actually over a year old. It represents the development of the community-based care coordination infrastructure in our 10-county region at approximately the same time that Unite Us entered Southwest Washington through a partnership with Kaiser Permanente. SWACH and our partner agency, our partner ACH, CPAA, were concerned by the potential disruption of a new data platform to the significant community-based care coordination work already underway. We were also very interested in the value of Unite Us to community and how best to work together collaboratively. Together with Kaiser Permanente, Unite Us, and the Area Agency for Aging and Disabilities, SWACH and CPAA formed a collaborative work group focused on alignment and the common goal of a seamless system of care to meet community member needs for whole person health. The term Community Information Exchange, or CIE, has often been used as an all-encompassing concept, which can be confusing. The work group distinguished between the two separate but complementary approaches to a community information exchange. Unite Us was a technology-driven community resource referral platform. SWACH and CPAA were models of a community-based care coordination-driven model driven by the community-based workforce. Kaiser Permanente and Unite Us released an RFP recently to incentivize Unite Us partnerships that included language developed in the work group. It said, quote, "Systems of care must include both community-based care coordination and technology-driven community information exchange models." So the University of California, San Francisco, and the CIREN Group had called out the same distinction between CIE approaches in their 2019 Community Resource Referral Platforms Guide. This guide focused on community resource referral platforms, including Unite Us. It compared and contrasted Unite Us and 8 other community resource referral platforms. The CIREN report also called out potential challenges of multiple platforms. This was our concern, the concern of SWACH and CPAA, when we understood Unite Us was entering Southwest Washington. The CIREN report had a few quotes that expressed this concern. Quote, "If organizations in a community implement different referral platforms, this will further reduce the likelihood that social service organizations will use the platforms." And another quote from a community-based organization leader, quote, "Now we're creating a world where community organizations are going to have 5 different websites that they're clicking on for referrals." In Washington State, this continues to be a concern as CIE initiatives do not appear to be consolidating around one single platform. For example, some major health systems are moving forward with Unite Us. Some major managed care organizations have partnered with Aunt Bertha, and there are already dozens of funded community resource referral platforms in operation in the state. The CIREN report called out that the ultimate goal of a more coordinated healthcare and social service delivery system requires either that we all use the same platform or that the platforms can easily interact. So, do we need to understand interoperability as the solidarity for the tech age? Do we need to prioritize alignment and interoperability across technology-driven CIEs in order to fully realize the promise and potential of these technology-driven CIEs? As I mentioned, the CIREN report did identify alternative and complementary approaches to community resource referral platforms. The report called out interoperability as one such approach. It also called out the community-based care coordination model implemented by SWACH and CPAA, specifically the Pathways model. This model centers community health workers employed by community-based care coordination organizations as the key drivers for increasing access and equity while improving whole person care. For the community-based care coordination model to be complementary with the technology-driven CIE models will also require interoperability. The technology partner for SWACH and the HealthConnect Hub and also CPAA's hub, the technology partner is Care Coordination Systems, or CCS. CCS is currently working with Unitas on interoperability between the two systems. For a truly aligned approach, CIE technology vendors such as Unitas and Aunt Bertha must be able to seamlessly refer to the community-based workforce and community-based care coordination infrastructure. It's a busy slide, but it was developed in the work group that I referred to before. The work group in Southwest Washington developed a shared vision of an enhanced network of care that aligns SWACH and CPA's community-based care coordination model with the technology-driven CIE of Unitas. The vision recognizes the value of a resource referral platform seamlessly integrating with a coordinated and connected community-based workforce. The vision is for Unitas to seamlessly and bidirectionally refer to a community-based care coordination infrastructure like HealthConnect that engages, supports, and champions a community-based workforce. The key to these two models maximizing their potential as complementary approaches will be interoperability between and across the respective technology platforms. We believe this must continue to be recognized as the top priority. Now I will turn it over to Michelle Ahmed, HealthConnect's Operations Manager, to describe HealthConnect's model for community-based care coordination.
Thanks, Eric. I'm having audio issues again. I'm sorry. First, I wanted to share a headline from 2 weeks ago, based on a report from the Commonwealth Fund. The US ranks last in healthcare among wealthiest countries despite spending the most. It might be last week's headlines, but I think it's something that we're all used to seeing. But it shows that we need to reconsider investment priorities to improve healthcare outcomes. HealthConnect's focus on community and the community-based workforce represents a paradigm shift in how we invest and how we support improved outcomes. Next slide. In considering investment priorities, we believe we need to shift so that we are centering community if we are going to successfully improve health outcomes. With HealthConnect, we are seeing improved outcomes in whole person care driven by the development and support of the community-based workforce. And this slide shows, our partners and activities and programs. HealthConnect community-based workers connect with community members needing support. The key is that they come alongside people in community, and we need to meet people where they are. HealthConnect support and investment in the community-based workforce has trained over 100 community-based workers as integrated HealthConnect partners. Community-based workers come alongside community members and assess risk and make plans to address them. These are called pathways, and over 15,000 of these pathways have been opened by community-based workers and the community members they support. The HealthConnect Hub connects referrals to community-based workers and then tracks the assessments, plans, and outcomes in a community health record. The data platform also automatically invoices for outcome-based payments to partner agencies when pathways are successfully completed. So an example is, housing is a huge problem, as we know, which determines health outcomes. If a community health worker supports a formerly unhoused community member in maintaining stable housing for 30 days, that's a successful outcome. The agency employing the CHW receives a significant outcome-based payment for that. This is the only functional value-based payment model that we know of in our state that is effectively investing in upstream community-based organizations to improve healthcare outcomes. Since HealthConnect launched Pathways in March of 2019, we have expanded the number of community-based care coordination models that are integrated in our community-based care coordination system to 7. Which are listed here. HealthConnect supports connection, coordination, and collaboration across these various programs. This creates a networked ecosystem of care. We refer to HealthConnect's role in this independent network as care traffic control. Next slide. So how does it work? Referrals come into HealthConnect, and community members needing support are connected by HealthConnect, a community-based worker employed by a partner agency. Community-based workers use a community health record for documentation. A CHR is a longitudinal record of assessment, care, and connections to service across whole person care needs. CHRs follow a community member as needed. They are not trapped in a single agency, program, or system. There are currently over 2,300 CHRs in HealthConnect's community-based care coordination data platform, and we are working with partners to upload over 12,000 more. A nimble CHR can effectively bridge previously fragmented and siloed systems and services. It supports the community-based worker who comes alongside community members and supports that community member to connect to services across siloed systems and sectors, across providers, and across geographic barriers. It can be helpful to understand how the model works through a case study. Eric will now take us through the case study of Jane Smith.
Thanks, Michelle. So this is Jane Smith's story. Obviously, Jane Smith has been de-identified. The first box in the storyboard sets up the categories. The top row shows whether Jane is being supported by the HealthConnect Hub. The second row shows the sector with which Jane is intersecting, and the bottom row shows where the story is taking place. In the second box, we see that Jane Smith is not yet supported by the HealthConnect Hub, and she's in community. She has opioid use disorder, and she lives in Klickitat County. The next box shows Jane at Klickitat Valley Health Hospital, which refers Jane to HealthConnect for support from a community-based worker. HealthConnect's partner agency in Klickitat County is a community-based organization that deploys a HealthConnect trained peer to meet Jane in the hospital. The peer has lived experience in addiction and recovery. As we know, peers are uniquely qualified in engaging with and supporting other peers. The peer connects with Jane, and it goes well. Jane and the peer agree to work together. The peer conducts an intake and an assessment of Jane's whole person care risks. And the assessment surfaces 3 main risks for Jane: housing, employment, and of course, opioid use disorder. Jane and the peer start working together on a care plan. She starts on medication-assisted treatment and begins work connecting with housing and employment services. But there's a setback. Opioid use disorder is a chronic disease of the brain characterized by relapses, and Jane relapses and is put in jail. She's not able to continue with her medication-assisted treatment program. So now we're in the 7th box, the bottom row. In jail, Jane is still supported by her peer. She is now intersecting with the criminal justice system, and she's still in Klickitat County. In the next box, Jane comes before a judge who agrees to release Jane on 2 conditions. She must continue to work with the HealthConnect peer, and she must secure inpatient treatment for opioid use disorder. Well, Klickitat County is a large rural area and it has no inpatient treatment resources. There are inpatient resources in Clark County, and that's several hours away. The HealthConnect infrastructure supports with care traffic control. The pier in Klickitat is connected with a HealthConnect trained pier in Clark County. They know each other anyway because they participate in monthly regional convenings of HealthConnect's community-based workforce, which you'll hear about a little bit more in a bit. So they know each other, and now there's a person-to-person connection and a warm handoff of support for Jane. Jane's assessments and her care plan has been documented in the community health record. The CHR is transferred to the Clark County pier. No unnecessary reassessments. The Clark County pier builds off of the work done so far. The Clark County pier has already preliminarily organized a bed in a treatment facility in Clark County before Jane arrived, and now supports her until she successfully completes her period of inpatient treatment. Then the pier works with Jane through the drug courts. After that, there's a smooth transition back to Klickitat. So now we're in the final two boxes. Jane is back in her community, and HealthConnect has transferred the CHR back to the Klickitat pier, who builds on it and continues working with Jane. And Jane's story is a success story. She's supported in continuing the work on recovery, employment, and housing, and she has since secured employment, has stable housing, and continues to be in recovery. The community-based workforce, the peers who connected with and supported Jane, were the key to Jane's success. HealthConnect's community-based care coordination infrastructure and the community health record provided the nimbleness, connection, and continuity of support that the peers and Jane needed to be successful. So now I'll turn it over to Nicole Peppers, HealthConnect's Networks Manager, who will go into further detail on how HealthConnect champions and supports the community-based workforce.
Thank you, Eric. The HealthConnect care coordination infrastructure is dependent upon the community-based workforce. They are essential to overcome engagement, navigation, trust, and cultural barriers to strengthen the connectivity crucial for Jane Smith and other community members to access systems and resources. HealthConnect is a mechanism for investment in and development of the community-based workforce. HealthConnect provides continuous workforce development opportunities on a monthly, quarterly, and annual schedule, including trainings, shared learnings that Eric referenced, and quality improvement. And we also provide ongoing mentorship, coaching, and technical assistance opportunities with a structured format, as well as a more organic needs-based support. For example, agencies meet monthly with Michelle and I for 6 months after completing Pathways activation training for guided goal setting and outcome reflection, as well as being able to drop in weekly for office hours for program or technical support. And every month, community-based workers come together for community cohort convenings. HealthConnect supports multiple cohorts monthly. And at the cohort convenings, community-based workers share learnings and best practices, connect with community resources and leaders, and provide one another with peer-to-peer support. The cohorts and trainings support development of the community-based workforce as individuals and also as a connected network working with one another across systems and programs. Next slide, please. So connectivity across programs is important. We have 7 integrated care models in the HealthConnect Hub. They are each valuable independently, but the underlying value of HealthConnect is in coordination and connecting across programs. As Michelle said, we call this care traffic control. I'd like to provide an example of the care traffic control benefit that the Hub provides in increasing access and connecting and coordinating across programs and providers. Let's take community paramedicine. Fire and rescue is deeply trusted in community. Clark Cowlitz Fire and Rescue is a HealthConnect partner agency with a community paramedicine program. which provides upstream support and referrals for community members who have high 911 utilization. A community-based social worker and a paramedic work together on a team with community members and document in the HealthConnect community health record. Previously, if the paramedicine team worked with someone who was also receiving support from another care coordination program, they would have no way of knowing except from the community member themselves. Now, if community paramedicine connects with someone who is already being supported by a program like Pathways or Health Homes, there is a community health record in the HealthConnect platform. The duplication is flagged by HealthConnect, and the HealthConnect team work with paramedicine and the other programs to support coordination and collaboration on care and best next steps. If there is no duplication and a person supported by community paramedicine would benefit from continued support by a community health worker, the paramedicine team refers them into the hub. HealthConnect then would support a warm handoff from the community paramedicine team to, for example, a Pathways community health worker. That warm handoff is strengthened by the fact that the paramedicine team and the Pathways CHW know one another and have already connected through networking at the monthly HealthConnect cohort meetings. Thank you. There are other such examples of connectivity and care traffic control. In the last year, HealthConnect contracted with the Washington Department of Health to launch the CareConnect Washington program in our region. This program is built upon the existing HealthConnect infrastructure and partnerships for community-based care coordination. Community health workers connect with and support people who are COVID positive to isolate and quarantine at home. They provide critical resources to stay at home during this time, such as groceries, rent, utilities assistance. And since launching in January, HealthConnect partners have served over 1,500 people through CareConnect Washington. Equitable access of resources is the cornerstone of CareConnect Washington, and the community-based workforce has provided supports to culturally and linguistically diverse communities across our region. COVID-positive households are often connecting to a community-based care coordinator for the first time while receiving CareConnect Washington resources. The quarantine and isolation period supported by this program is relatively brief, but many community members need continuing support. The community health worker refers them to other programs like Pathways or Access to Health. Often it is the same community health worker who is cross-trained and provides the continuing support. Cross-training as many community health workers in Pathways and CareConnect Washington was a priority. And to date, all community health workers providing both CareConnect Washington support are cross-trained in Pathways. I want to share a story to illustrate the importance of this cross-training and connectivity. Recently, a Latinx Spanish-speaking community health worker provided CareConnect Washington programming for a Spanish-speaking client. At the end of his quarantine, she offered longer-term care coordination through Pathways. He inquired if other members of his family were eligible for Pathways, and she explained that as long as the other families selected to enroll in Pathways and gave consent, they were. He asked if his sister could call the community health worker because he felt like she could benefit. His sister, a young woman also Spanish-speaking with DACA, was needing critical behavioral health care that she didn't know how to access on her own. She gave consent to be enrolled in Pathways and also asked if her mother could talk with the community health worker, so she gave consent for her mother to talk with her. Together, the community health worker was able to complete the Pathways enrollment and begin the model with the young woman. A few months in, the woman engaged in inpatient behavioral health treatment. The mother was unfamiliar with the behavioral health care system in the US, and the community health worker was able to explain to the mother what her daughter should be released with from the hospital, including a care plan, and how together they could advocate for what she needed with her doctors. I share this story as an example of the critical role a community health worker plays in community care coordination and helping create access across systems. It's also worth highlighting that the family may never have received the needed behavioral health support through the Pathways program if they had not first been engaged through the CareConnect Washington program. HealthConnect supported that essential continuity of care. While we don't have time to delve into all 7 of the programs and how they can interconnect, I want to highlight the Pathways program, which was HealthConnect's first community care coordination program. Pathways participants may need varying support, but HealthConnect data shows they generally have complex, intersecting conditions, including physical health, behavioral health, and social needs. They also have high socioeconomic barriers. Over 70% report less than $10,000 annual income, and they have high housing insecurity. Approximately 40% are unhoused, with 60% reporting housing concerns. And they have high health burdens. Nearly 80% report multiple health conditions, and nearly
Sorry, did we lose you, Nicole? Yes, it looks like we did for a moment. We'll give you a chance to reconnect.
Sorry, I think my audio cut out there.
Yeah, we can hear you now.
yeah.
Okay, great. So I'm going to just pick back up where I think I left off, which is HealthConnect community-based workers have initiated over 15,000 pathways to address identified risks and have successfully completed 2/3 of them with successful outcomes. In particular, I'd like to call out the engagement and enrollment rate of 77%. This is the percentage of people referred to pathways who choose to enroll in the program. This high enrollment rate speaks to the importance of the trusted community-based workforce who can meet people where they're at in community and who can quickly establish trust to connect, engage, and support. This is a busy slide, but I would like for you to read the 3rd column to see a picture of representation across the hub. The 3rd column in the table represents the cultural and community lived experience represented in the HealthConnect trained workforce. Our 3-county region is diverse. The trained workforce here is representative of the diversity in the region. The cultural, linguistic, and lived experiences are foundational to the HealthConnect model. When a community member has the opportunity to meaningfully connect with a community-based worker in their native language who shares similar values and understandings, they are more likely to engage and stay engaged in care coordination support. Traditional healthcare systems cannot meet these needs in the same way, and to expect them to is unrealistic. Community-based access for health provides an additional level of critical care and support. HealthConnect used a strong equity lens in developing agency partnerships. We focused on engagement with community-based agencies who are established cultural and lived experienced experts through their workforce. And HealthConnect CareConnect Washington program includes a culturally appropriate response and engagement cohort of community health workers, providing services who are diverse in culture, language, and lived experiences. The acronym for this cohort is CARE, the CARE cohort. The positive success of HealthConnect in supporting and engaging a culturally diverse cohort of community-based workers has led to expanded partnerships and funding opportunities to advance equity and access for community members. This includes a recent $1 million grant from HRSA to promote COVID-19 vaccine information and access through engagement of culturally relevant workforce. The grant included significant funding directly into the community-based workforce. This grant was built upon the success of HealthConnect's care cohort and likely would not have been possible without the engagement of the trusted community partners. I'm going to turn it back to Eric now for evaluations, outcome, and sustainability.
Thanks, Nicole. So the HRSA grant is an example of the power of HealthConnect as a model to reorient investment priorities to community in the effort to improve whole person care, increase access, and advance equity. As we shift the framework to community, we must solve for strategies that sustain the community-based care coordination infrastructure and invest in the community-based workforce and the agencies that employ them. SWACH and HealthConnect are accountable to the community. We must continue to demonstrate proof of concept for this model of community-based care coordination to our community partners and funders. And we must be able to evaluate and report on impact and on return of investment if we are to sustain this model. To accomplish this, SWACH is contracted with an independent team of scientists, researchers, and data experts at CORE, the Center for Outcomes Research and Evaluation. CORE regularly supports with reports based on surveys and deep data dives. For example, a CORE report last summer surveyed over 100 regional partner organizations to understand what community and clinical partners saw as the highest priorities for sustainability of SWACH activities. What work should continue beyond the 5-year Medicaid transformation project into the future? The top 2 priorities identified were continued support of the community-based workforce and continued development of the HealthConnect Hub. Other evaluation reports include deep dives into specific HealthConnect program impacts. A recent report focused on the experiences of the HealthConnect partner agencies and the community-based workers who are trained in delivering the Pathways program. Findings from the report reinforced the value of HealthConnect. The report showed HealthConnect represented a strong care coordination ecosystem and provided continuing growth and development of the community-based workforce. This quote from leadership at one partner agency captured the essential value proposition of HealthConnect community-based care coordination infrastructure. Quote, "We wanted to participate in the Pathways program because we recognize that there's a deep need in the community. These existing needs don't tie to other work being done by organizations. Pathways is able to address a whole bunch of needs and make linkages across providers to achieve whole person care for program participants. This program has broadened our ability to work with other agencies." As the work evolves, how can we ensure accountability to our communities, partners, and other stakeholders? We've developed a framework to consistently measure key performance indicators, essentially a driver diagram. The framework is grounded on 5 foundational elements. These are the key change concepts that drive the work of SWACH and HealthConnect. Each foundational element has its own strategies and associated measures. Core data scientists provide independent evaluation support to determine the measures, and SWACH will report out to community on a regular cadence. The measures let us and community stakeholders know if specific changes actually lead to an improvement. The 5 foundational elements or key change concepts for SWACH and HealthConnect are community engagement and power building, the coordinated service model, the data and program infrastructure, the community-based workforce, and community investment, finance, and sustainability. Measurements from the key performance indicators roll up into a broader evaluation of the midterm impacts and outcomes of the work of SWACH and HealthConnect. Midterm impacts provide an overview and provide answers to key questions and guiding principles for this work to be successful. Understanding the midterm impacts of the work in progress provides an opportunity to consider questions such as, how have we invested in community and have we invested equitably? Did we effectively collaborate and solve problems together? Did we effectively recruit and support a diverse community-based workforce? Did we effectively work with our partner agencies to support community members in improving whole person care? And did we reach and support access for priority populations? Reporting of midterm impacts will ensure SWACH and HealthConnect's continued accountability to community, to agency partners, to funders, and other stakeholders. Finally, we need to look at long-term impacts and outcomes. This is why Washington State moved forward with the Medicaid transformation project in the first place. Again, our partners at CORE will be analyzing and cross-mapping data across systems and sectors to measure the impact of SWACH and HealthConnect work. Is our work impacting hospital readmissions, ED utilization, recidivism, and 911 call rates? How do these impacts affect costs? Are there associated cost savings? And crucially, how can these cost savings be effectively reinvested into the community, invested into the community-based workforce, and invested into the community-based care coordination infrastructure? Ultimately, the HealthConnect model for community-based care coordination seeks to answer the question of how best to reinvest in the community. We know that as much as 90% of health outcomes are determined by factors in community, and we know that we need to change our investment priorities. Our hope and our belief is that the HealthConnect Hub is a model for that reinvestment and a powerful mechanism for stabilizing crisis, building resiliency, advancing equity, and improving whole person care outcomes. And that's our presentation. So thank you for allowing us to share this evolving work with you.
Thank you so much, Eric, Nicole, and Michelle. It's so wonderful to hear about the great work that you're doing in Washington, and particularly love the term care traffic control. I think that's great. So I am going to invite the group. If you have a question, please put your name in the chat. I will call on you and ask you to open your line and communicate directly with our presenters. So I invite you to do that now. In the meantime, I had a question for the three of you. I have a few, but the first one is, what would you say are the top 2 to 3 lessons learned that you've seen in this work in connecting community-based organizations and health organizations?
Anybody want to take a stab at that?
I guess I will. I think that, just looking back at the last 2.5 years, when we started thinking about what we wanted to do, which was create this community-based care coordination system, we didn't have all the buy-in from all of the stakeholders. We didn't wait to start. We just started with the partners that we had, creating the Pathways program. And, because you think about all of the data sharing needs that there are and the funding and everything like that, it gets overwhelming. But we are able to start with the partners that we had and create some good outcomes in that created a critical mass, which attracted more partners and even attracted some funding and more models. And, if I think a lot of times with these community projects, they just the change seems so hard and, so overwhelming, but you just start with the little that you have. Now we haven't gotten all the way there, but we're certainly a lot closer.
Yeah. I just want to echo the importance of the Institute for Healthcare Improvement talks a lot about small tests of change, and I think that's been our approach with our partners from the beginning. I also think that we've really come humbly and in full partnership to the relationships with our community and agency partners. We're figuring it out together. So we've built in processes around improvement and shared reflection, PDSA cycles, and there's a sense that we're building this together. And I think it's been important to show up in a humble and collaborative mindset.
And I think to add on that, when we started, we of course had funding from the Medicaid transformation, which is a lot more than a lot of Pathways hubs are able to start with. And it was a model that the state, what's the right term for it? Not prescribed, but if we wanted to pursue care coordination, they highly suggested that we use the Pathways model. But which is a great model. It does a lot. It provides for outcomes-based payments and data tracking and all of that, but not every, you know, even though it was prescribed state down, I think the community we didn't have all of the buy-in from the community with that particular model, but just by listening to partners, like Eric said, and working with partners, that's how it kind of evolved into a system that's able to accommodate lots of different care coordination models that exist out there, and make sure that, you know, community members aren't getting stuck between models, you know, the traditional fragmentation and siloing that comes from that.
Great, thank you. So what's next? What's next for SWACH and HealthConnect? What are you excited about?
Nicole, do you want to lead us on that one? We'll just jump on.
Absolutely. There's a lot we're excited about. And the central part as we move forward, our core will be around continue to be around the community-based workforce and ensuring that the community-based workforce is centered in our work and our growth. And I think HealthConnect is in a really exciting spot, as you saw, like the connectivity and the collaboration around our models and pathways as the foundational model for HealthConnect, and the sustainability plans around that too are exciting as we move forward.
Yeah, I would say, to piggyback on that we're just arriving. I mean, I think there's been meetings with Michelle, Nicole, and I, and other members of the HealthConnect team. We have a fantastic team. In fact, I'm just going to give kudos to the whole organization while I have the platform. But there's been moments where we've kind of looked at one another and said, I think we might be out of that initial, you know, intensive small tests of change piloting mode, and now it's time to stop expanding and really deepen and strengthen the programs, our partnerships, sustainability opportunities and funding. So I think, you know, in terms of what's next, I'm not quite sure I'm ready to say we're ready to get out of startup mode, but we are in a different phase, and we need to continually evaluate and advance the work, and look at the outcomes and be able to demonstrate proof of concept, as well as continue to make sure that the lens within which we work is really an equity lens, and that the data and the community experience of working with HealthConnect and how HealthConnect supports is backing up our aim to advance whole person care through that equity lens.
Yeah, and to continue with that, HealthConnect, I think we're moving closer away from the startup phase, absolutely. It doesn't change how nimble and responsive we are and prioritize the equity lens in our community-based workforce. And when we launched CareConnect Washington, which is the COVID response program, back in January, it still was very unclear of how COVID was going to continue to impact our communities and our healthcare systems, and just our care systems. But as we've continued on, and I think just collectively had a greater understanding and awareness of the continued long-term impacts for communities due to COVID, that model will continue to become an important model in our build out, because it did really show that in addition to long-term care coordination model pathways, that we are also able to quickly engage and build a model that is a crisis-oriented model through CareConnect Washington, and engage the community-based workforce appropriately. And so they are meeting their community members where they're at and providing those services. So I think that the nimbleness and the responsiveness will still stay true to HealthConnect. It's part of our core.
Great. Thank you so much. And we have some questions from the audience. We have 3, and so I'm going to push us to get to all 3 in the next 10 minutes. So Tao, I invite you to open your line and ask your question of our presenters.
Okay, thank you very much, Mary. Thanks, all the presenters. I'm Tao Li. I'm one of the medical directors of Health Network California. Very interested in the work that you do. I just have a couple questions. First of all is, what is the role of the PCP or the psychiatrist of your clients when the clients going through the system? Number 2 is, which platform the community-based worker use to document their work? And finally, if the Kaiser patient use your system, how do they pay you?
Okay. Michelle, do you want to start with what's the role of the PCP or the medical or behavioral health provider?
Sure. They play several roles. A common role is a referral partner. So we receive referrals from PCPs and behavioral health systems quite often when they identify that they have a patient who needs support in the community. They also receive our referrals. So, we identify community members who need medical homes, who need care from their primary care provider, or behavioral health. We have, in the Pathways program, there are specific outcomes related to finding a medical home or receiving treatment through behavioral health. We also work with them. It's pretty common for community health workers or community-based workers to go to appointments with patients. One of our outcomes is to help with medication management. So a community-based worker would document what medications a person is taking, how they're taking it and how they understand it, not based on what the prescription says or what the medication list says. And then communicate with the provider's office or the behavioral health office what the patient is doing at home, because they get that view of what they're doing at home, and the provider is able to respond if they need an appointment or ask questions, all of that. So there's a few ways that healthcare providers interact with the system. And sometimes it depends on the partnership and, or the client.
Great. And then your other question was, what platform does the community health worker use? And if you mean what's the technology vendor, we are partnered with Care Coordination Systems, or CCS. They developed their technology platform alongside the Pathways program when it developed first in Ohio. So they're very, we've appreciated that their build out has been very centered on usability by the community health worker. And then we continue to work with them as we innovate to support community needs and multiple programs integration. They've been design partners with us, strategic partners, around how best to develop out this infrastructure. So we're using community care coordination systems, but I do want to take the opportunity to say that, that's not necessarily the only technology that provides support for community-based care coordination infrastructure in Washington. There's other technologies as well. And it really just heightens the initial point of this presentation, which is we need to really be focusing on interoperability, that we have multiple systems. They all need to be able to work together. And it's a heavy lift, but it needs to be a priority and a commitment. The last question you asked was, let's say a system like a Kaiser patient is using the system. So how does the funding work? How would Kaiser pay? So we have contracts now with, and we're getting into that place of developing sustainability models and contracting around payment. We were fortunate enough, as Michelle was saying, to start with the Medicaid Transformation Project funding, which was, startup funding for these tests of change. And as we think about sustainability, we need to get to a place where we have partners who are interested in helping to continue pay for this proof of concept of the overall structure. And then we have partners who are interested in paying for the outcomes. And that's one of the beauties of an outcome-based payment model. For example, we've recently contracted with the Veterans Advisory Council in our region. And they are referring veterans who could use support of a community-based worker into our system. And as that community-based worker makes a care plan and successfully connects people to services, the key is that successful outcome is attached to a payment. And the Veterans Advisory Council has provided funds to cover that outcome-based payment. So as we move forward and there's more value recognized by partners, by counties, as with the system as a public utility or to directly support their patients, there's multiple ways that funding could work.
Eric, thank you very much. I just want to make a comment is value-based payment is very difficult to manage. And then for a startup company, I would suggest to get something, keep it simple in order to sustain your wonderful work, because value-based outcome is a huge animal. It's very difficult to manage. You don't want to lose your shirt in doing the value-based payment. Thank you very much.
Thank you. All right, I'm going to push us to do one more question in 3 minutes. So Masood, I welcome you to open your line, introduce yourself and ask your question.
Great, thank you very much. My name is Masood Agahi. I wear a few different hats. I'm a physician. I also train community health workers using a program that we've set up in partnership with several other partners throughout California. And my question is regarding CHW involvement, and Nicole was very kind in answering a question earlier. I appreciate that. But also I wanted to kind of tie in some of the other comments. For example, the fact that the payment system for community health workers is at best very unstable and dependent on specific grants that may be here today and not here tomorrow. How do you ensure that, since that's such an important aspect of your program, to make sure that you have a stable base of CHW, that they are adequately supported and funded and so forth? Thank you.
Yeah, I don't think we certainly don't pretend to have all the answers to that, but I think that one of the keys is that we're working closely with the agencies, our partner agencies who are hiring, and working with them around rated funding opportunities. For example, I'll give you an example. The CareConnect Washington program through DOH. That program includes funding for FTEs for community-based workers. And so some of our partners had already hired community-based workers to be doing pathways or, let's say pathways. And then with that CareConnect Washington Department of Health program, there's an opportunity to bring that federal funding to fully cover the FTEs of those CHWs. The HRSA grant that we just were able to leverage also supports funding for community health workers to specifically support information and engagement and uptake for vaccines. Well, they were doing that already. So there's another opportunity to bring the funding in to support FTEs. And then with that as well, the outcome-based payment model has been calibrated, and we continue to check this so that if a community health worker is able to maintain, a caseload, a consistent caseload, and we support them in invoicing, the funding that they receive from outcome-based payment should cover an equitable living wage.
Great, thank you so much. Thank you, Eric, Nicole, Michelle. We very much appreciate you sharing your work with us. It's so wonderful to hear what you all are doing north of us. So thank you so much. Thanks everyone for joining the call. Please take the poll. We want to know how we can continue to support you, and appreciate everyone being here today. I hope everyone has a great rest of your day.
Thank you.
Thank you, everyone.
Bye.
And we
Thank
look
you.
forward to thought partnering with any and all.
All right. Take care. Bye.
Thank you.
Bye.